Good evening. My name is Professor Leanne Young, and I teach the maternal and newborn nursing class for Fortis College. This week, we are going to be talking about high risk antepartal care, which is chapters 11 through 12 in your textbook. This is a lot of content, so we're going to move through everything pretty quickly in this recorded lecture. So please feel free to pause and take notes as you need to. We're also going to be reviewing a lot of this stuff in class this week as well, just so that you guys get even more information about it because this is quite a lot of content. Okay, so let's get into it. So the first thing that we're going to talk about is diabetes mellitus. So whenever we talk about a high risk antepartum patient, something that can make a patient high risk during their pregnancy, during their delivery, one of the biggest things is diabetes. Okay, so obviously we're going to split these two into groups. So we have pregestational diabetics and then we have gestational diabetics. This might be self-explanatory, but we're going to go over what these mean really quickly. So pregestational diabetic is a term given to a woman who has had type 1 or type 2 diabetes prior to pregnancy. So these are women that have been dealing with this disease before the onset of their first pregnancy. Okay. Gestational diabetes, you guys can put these two together. This is what happens whenever women develop diabetes during their pregnancy. Okay. It's the carbohydrate intolerance that develops during pregnancy. So, what are the major metabolic changes that happen in our body during pregnancy? What can we expect? Is there any difference between our first trimester and our second trimester treatment for these diseases? So, you guys should know already that diabetes refers to a group of metabolic diseases characterized by hyperglycemia, resulting from defects in insulin secretion, insulin action, or both. These are typically classified as your type 1 or your type 2 diabetes. Type 1 diabetes is the absolute insulin deficiency and an abrupt onset of illness at a much younger age. So, this is whenever people are diagnosed, whenever they're kids, typically. Type 2 diabetes develops typically because of lifestyle choices, which result in decreased insulin secretion and insulin resistance. Okay, so that should just be a review. You guys should be learning that in your med-surg class. You should have had that in anatomy and phys at the start of your nursing school. The metabolic changes that happen during pregnancy. So during a normal pregnancy, adjustments in the maternal metabolism allow for adequate nutrition for both mom and the developing fetus. Glucose is transported across the placenta, which means the glucose levels in the fetus are directly proportional to maternal levels. So whatever your blood sugar would be, your baby's blood sugar is going to be very similar to that. In the first trimester, rising estrogen and progesterone levels greatly influence the pregnant woman's metabolic status. So these hormones, what they're going to do is they're going to stimulate the release of beta cells in the pancreas to increase insulin production, which ultimately promotes increased peripheral use of glucose and decreased blood glucose. Therefore, what does that mean? Right? That's a lot of words. Women with insulin-dependent diabetes are prone to hypoglycemia during the first trimester. So we need to be really careful and we need to educate our patient on what kind of signs and symptoms would they expect relating to hypoglycemia? What could they experience? Would this mean increasing or decreasing the amount of insulin that they receive every single day? If a woman is used to receiving a shot of Lantus in the evening, as well as, a sliding scale at meal times, she might need to decrease the amount of insulin that she's taking in the first trimester because they're prone to hypoglycemia. So we don't want to make that worse. During our second and third trimester, because of the major hormonal changes and fluctuations, maternal insulin requirements gradually increase from approximately 18 to 24 weeks of gestation until about 36 weeks of gestation. So the insulin requirement may double or quadruple by the end of pregnancy. So at the beginning of pregnancy, our first trimester, we're telling moms, let's lay off the insulin a little bit. We're going to decrease the amount they're receiving every day. And then towards the end, second and third trimester, we're increasing that. A lot of that has to do with taking into account the growing fetus, being able to supply enough glucose and insulin for both mom and baby at a safe rate, right? We have to take into account that this baby is growing at a rapid rate, so we have to increase the insulin demands. Okay, so what are some risks that we see with diabetes in pregnancy? Macrosomia is the biggest one, okay? So that little baby over in the corner, I shouldn't say little, is a macrosomic infant. That's a baby that is large for gestational age, typically even larger than a LGA baby would be. Any time mom has an issue with her with diabetes in pregnancy, we run the risk of also developing hypertension, whether it's pre-existing or if they develop gestational hypertension during the pregnancy. Preeclampsia can also result from diabetes as well. One big thing, which I know that we talked about briefly a couple weeks ago, is moms who are diabetic. We also see instances of polyhydramnios. So, what is our normals for amniotic fluid, right? Polyhydramnios means an excessive amount of amniotic fluid. So, anytime that a mom has over 2 liters of amniotic fluid, she would be considered to have polyhydramnios. And that is often seen with diabetes, definitely. The other thing is mom can have a crisis, DKA, diabetic ketoacidosis, that can occur during pregnancy. And that's very dangerous for both mom and the baby. So, what are our assessments? We need to assess mom's baseline renal function, get a urinalysis, a culture, an A1C. Do we need to educate this mother further? Like, do we need to tell her about her insulin demands in the first versus in the second and third trimester? What are the potential risks to our moms or potential risks to the babies, right? And goes along hand in hand with just our typical untreated diabetes. So, that diabetic ketoacidosis can occur. If a baby is too big, it can run into a lot of different type of respiratory distress disorders after delivery, which we need to be careful about. So, how do we tell these moms during pregnancy to manage their diabetes? The biggest one is diet. So, typically, these patients are going to be referred to a nutritional specialist or counselor to help them manage their diabetes. Someone who's been used to controlling their diabetes outside of pregnancy may find it harder to manage their diabetes during pregnancy. So, we need to kind of help with the nutritional aspects, limiting the amount of processed foods, fatty sugars, fatty carbohydrates, increasing their diet with good sources of fiber and protein are going to be essential. Exercise, so 30 to 60 minutes a day is encouraged for any pregnancy, for any mom, but especially for our diabetic moms. Okay. Our insulin, so our dosage is going to vary during pregnancy, and those patients should be managed closely by an endocrinologist. So, an acceptable fasting levels are between 60 to 105. 1 hour post meal levels should be less than 140. So, we need to tell them that they need to be monitoring their glucose at home, monitoring using a glucometer or a pump, an insulin pump, or an automatic reader. Test their urine for any protein or glucose in their urine, which can indicate that they're developing preeclampsia or something else that can be sometimes more severe. As far as fetal surveillance, infants are at a risk for congenital heart defects and neural tube defects, as well as anencephaly. So we need to perform extensive testing throughout the pregnancy to monitor the fetus closely. So since this is a high-risk pregnancy, especially in our moms who are pre-gestational diabetics, these patients might undergo more invasive testing like that chronic venous sampling or the amniocentesis, just to make sure that baby is developing sufficiently and that there's no other underlying risk factors that we could be running into. Okay. Um, as far when we talk about determination of birth date and mode of delivery, that just means, are we going to allow this mom who is a gestational diabetic to go all the way to 40 weeks of gestation? Most of the time, no, we don't. If insulin dependent, then there's a chance that the OB provider is going to want the infant delivered earlier than 40 weeks of gestation. But like I said, this depends on our fetal size, if the diabetes is well managed or controlled, or if mom has any underlying medical conditions that have occurred because of this gestational diabetes, like polyhydramnios, hypertension, or preeclampsia. Okay, so these patients are most likely going to deliver before 40 weeks. Gestational diabetes. Okay, so these patients compared to pre-gestational diabetics are going to have fewer risks associated during their pregnancy. Okay. Risk factors for developing gestational diabetes: if there's a family history of diabetes, if the mom is obese before she becomes pregnant, if she already has chronic hypertension, and then a maternal age of over 25 years. Women who have gestational diabetes have a higher chance of developing type 2 diabetes later in life, so we need to educate them as far as healthy weight loss after delivery, healthy diet and exercise, and lifestyle after delivery. So, we kind of went over the treatment. That's the same with gestational diabetics: diet, exercise, self monitor your blood sugar. It's rare that we give gestational diabetics meds, but we can if it's severe enough and it's uncontrolled. And then obviously we're going to be monitoring their babies pretty closely. Okay. So, how do we diagnose gestational diabetes? This is diagnosed using that glucose test during pregnancy. So, the glucose test is a screening tool that is used between 24 to 28 weeks. So, your late second trimester. It's a two-step screening method. So, the patient is going to come to their OB appointment. They typically drink a 50-gram oral glucose solution. Then they have her blood sugar tested 1 hour after. Um, any result higher than 130 or 140 would be a fail, and she would need to come back and do a 3 hour glucose test. If she fails both of those, then she's going to get the diagnosis of being a gestational diabetic. If she passes the 3 hour, they might still have her monitor her blood sugar at home and monitor and change like diet and watch her lifestyle. But if she fails both, she'll be diagnosed with gestational diabetes. Okay. For these tests, the patient does not need to fast for the test, which is a common question that we get about these tests. We actually don't want the moms to be fasting because that can put them in an insulin resistant state and can increase the likelihood of them failing their 1 hour. So we tell them to kind of eat as normal as they normally would, and then they just can't eat, drink, or eat anything after they've taken that glucose drink. Otherwise, it can interfere with the test. Okay, moving on now to our thyroid disorders. So, in pregnancy, your thyroid gland is going to naturally enlarge. So it's not uncommon for women who have never had any issues with their thyroid to develop problems with their thyroid during pregnancy. It's actually like relatively common. But it also depends on like which one. Typically, hypothyroidism is more common in pregnancy because of that enlargement of the thyroid gland, but hyperthyroidism can still occur. So, when we talk about hyperthyroidism, it's pretty rare. It occurs in about 1 to 17 births in 1,000. Like I said, hypothyroid is typically what we see more whenever we're talking about thyroid disorders. You guys should know your clinical manifestations of hyperthyroidism versus hypothyroidism. So, for hyperthyroidism, these patients are going to have a heat intolerance. They're going to have diaphoresis, so they're going to be sweating a lot. Fatigue, anxiety, emotional lability, and tachycardia are common. Some patients will also complain about palpitations. Okay. Patients who have pre-existing hyperthyroidism are at an increased risk of miscarriage, preterm birth, maternal preeclampsia, and maternal heart failure. So we need to monitor these patients very, very closely. Treatment for hyperthyroidism is typically I can't even say this word, propylethoruracil or methimazole. Like I said, I can't pronounce those correctly, so just double check the pronunciation on those. We need to be really careful with medication treatment because these meds have some very severe side effects, okay? Um, Hepatic toxicity is one of them. So that first one, the one that I can't pronounce, we're going to abbreviate it as PTU. PTU can only be used in first trimester due to possible effects on the fetus. You cannot have radioactive iodine during pregnancy because it may destroy the thyroid of the developing fetus. So sometimes the best thing to do is to remove the thyroid completely and give mom replacement. So Synthroid. Basically, they would be hypothyroid after the removal of their thyroid gland. So we would treat them as a hypothyroid patient. Okay. So next one, this brings us to hypothyroidism. This is much more common, like we said. Clinical manifestations include weight gain, lethargy, decrease in exercise capacity due to that fatigue, and cold intolerance. With a hypothyroid patient, the labs that we're going to see are an elevated TSH and low T4 levels. These patients have an increased risk of infertility, miscarriage, preeclampsia, placental abruption, preterm birth, and stillbirth. So they need to make sure that they're getting their thyroid levels checked pretty routinely throughout their pregnancy. Typically, OBs want their patients checked every 4 weeks in pregnancy, if not every trimester during the pregnancy. The treatment for hypothyroidism is levothyroxine or Synthroid. They need to take this every single day. Know the rules for administering or taking Synthroid. So these patients should be taking it an hour before they have anything to eat or drink. First thing in the morning, they should not be taking it alongside any other vitamins, especially not like calcium or anything like that, because it can interfere with the absorption. Okay. So we will definitely need to know those rules. Okay, moving on, we're going to talk about cardiovascular disorders next. Okay. Your textbook goes into much greater detail in the subsections of each cardiovascular deficit and abnormality. Please take the time to review these on your own time. We are going to be talking more extensively on hypertensive disorders because these are much more common. Okay. I want to spend a lot more time on hypertensive disorders like preeclampsia and chronic hypertension. Because we see these way more frequently in maternal fetal medicine than the other ones. Not that the other ones aren't prevalent and that they don't happen. We're just going to spend some more time on the ones that are more commonly occurring. Okay. So the cardiovascular system goes through many changes during pregnancy, like we talked about in weeks, if in your content for your first exam. If the body does not handle these well, it may result in cardiac failure. Fever is a major cause of cardiac decompensation during pregnancy, which is why we always tell moms if you have a temperature, you need to call into your OB. And we're going to be recommending them to take Tylenol every 4 hours until their fever subsides. Fever during pregnancy is pretty dangerous for both mom and the developing fetus. This affects only 1 to 4% of pregnancies, and it's higher risk in women with pre-existing conditions. So, cardiovascular disorders, there's many. Like I said, your textbook is going to go into a lot greater detail. Um, this would be considered a high-risk pregnancy. So, for antepartum and postpartum, we want to minimize stress on the heart. So we need to teach them signs and symptoms of decompensation, which would be like dyspnea, tachycardia, edema, any typical decompensation that you're going to see with any cardiovascular disorder. Okay. Well, you're going to assess for signs and symptoms of cardiac heart failure, like chronic heart failure, like generalized edema, jugular venous distension, dyspnea, palpitations, and a moist cough. We're going to assess them for signs of a VTE and then encourage them to avoid straining and constipation. So these patients who have a cardiovascular disorder or who have a pre-existing cardiovascular condition are going to be on regimented stool softeners because we do not want them to vagal. We don't want them to vagal down. So we're going to tell them to avoid straining and constipation. Same with like any other chronic heart failure patient. We're going to have them do daily weights at the same time, most likely naked, every single day. And if they gain more than 1 or 2 pounds, they need to call their primary care. limit their physical activity because we don't want putting additional stress on the heart. And then for interpartum, help moms to manage discomfort. We're going to help position them to support cardiac function. And then whenever it's time to push with the patient, so this is when they're in labor, we're going to do open glottis pushing. So whenever the mouth is open and they're still doing breaths with their pushes, rather than closed glottis pushing, which is when they're straining, basically like if they're pooping, right? Same concept. So we don't want them to strain. We don't want to have them vagal down. Our interventions in antepartum, if they develop an infection, it's going to be treated promptly because that can put some stress on the heart and cause their condition to worsen. We're also going to monitor for iron deficiency anemia, which can go hand in hand with any type of cardiovascular disorder. Um, and these patients are going to be sent to a nutritional counselor to be on a sodium restricted diet to help lower their blood pressure and ensure that they're well regulated. During labor, we're going to monitor their pregnancy during their delivery and labor. We're going to follow the pregnancy closely and adjust the typical pregnancy or labor teaching. Like we talked about, we're going to implement that open glottis pushing rather than closed glottis pushing. After delivery, we're going to monitor for cardiac decompensation, especially in the first 24 to 48 hours after birth. And then, um, if they hemorrhage, these patients are going to be at an even higher risk. So we need to make sure that we control any type of bleeding promptly. Okay, let's discuss anemia. This is a very common disorder of pregnancy. It occurs in about 20 to 50% of all pregnancies. The most common is iron deficiency anemia. It's diagnosed whenever your serum ferritin levels are less than 12, along with a low hemoglobin. Okay, these patients, their treatment are going to be iron supplementation for their anemia. Folic acid deficiency anemia. This is the importance of the prenatal vitamins or a diet that's high in folate, which I have a picture over there of high folate foods. So like leafy greens, broccoli, beans, those kind of things. This is essential for our spinal cord development, right? That should be ingrained in your guys' brains. I feel like I've said it so many times, but your neural tube disorders develop and can have an increased risk for them if mom is low in folic acid. So she needs to be taking her prenatal vitamins, especially if she has a deficiency. Sickle cell is the sickling of the red blood cells. That's that image in the top left-hand corner of your slide. This is more common in the African American population. Sickle cell crisis. So, if you guys have not ever been around or treated a sickle cell patient, it is extremely painful for them. They are in a world of pain whenever they come in sickle cell crisis. That is basically whenever their bloodstream does not have enough oxygen because of the sickling of the red blood cells. So their entire body, they have a systemic reaction. Common things that can send people into a sickle cell crisis are abrupt changes in temperature, changes in elevation or pressure. So, like if somebody were to go on vacation who has sickle cell crisis and they live in Miami, Florida, and they go and they are hiking in the Rocky Mountains in Colorado, that can put them into a sickle cell crisis. So, we need to educate these patients on being careful about that. Any type of exposure to an allergen can increase the risk of sickle cell crisis. And like I said, they're in excruciating pain. They can come into the hospital and usually receive treatment and they have to be monitored. Their treatment would be blood transfusion. We have to avoid the triggers and then folic acid supplementation to assist with the regeneration of those red blood cells. Thalassemia is an insufficient amount of hemoglobin that's produced to fill the red blood cells. This is a hereditary disorder and it may require transfusions during the pregnancy. Asthma. So this is a chronic inflammatory disorder of the tracheobronchial airways, and it's triggered by allergens and other irritants. The effect of asthma on pregnancy is relatively unpredictable. Okay. Our biggest goal in pregnancy with any patient who has a history of asthma is preventing attacks. So we're going to educate patients on avoiding triggers and allergens and help them to maintain medication regimen prescribed by their physician. Integumentary disorders. This is very, very common in pregnancy. So, pruritus gravidarum is a generalized itching without the presence of a rash. The risk can be multiple gestation, fertility treatment, diabetes, and nulliparity. So, the patient has never delivered a fetus over 20 weeks. Treatment would be just lotion and oral antihistamines. Okay. The next one we're going to talk about is polymorphic eruption of pregnancy. This occurs in prima gravidas during the third trimester. So that is a first time pregnancy that is happening, and they're in their like last trimester of pregnancy. For some reason, it occurs mostly in women carrying male children. I'm not entirely sure why. The treatment would be antipyretic topical meds, topical steroids, or antihistamines. The biggest one on here that I want you guys to know is your intrahepatic cholestasis of pregnancy. So this is liver disease in pregnancy. The biggest symptom of it is women complain of their palms and the bottoms of their feet itching like crazy. And not just like, oh, I'm a little itchy. Like these women cannot stop itching. They will like split their skin open. They will have open cuts and wounds. They're itching so aggressively. Okay. It's way worse at night. They can't sleep. They're not sleeping because of this itching. And it's something that can be an emergency for the baby. So they need to let their OB provider know about this immediately. How do we diagnose it? They're going to have elevated serum bile acids on their liver function tests, and we also need to perform extensive liver function tests to assess the function of the liver. Treatment is going to be this med. I'm not going to try and say it. And we must monitor the infant closely. So sometimes with cholestasis, I've seen women get induced as early as 37 weeks of gestation with this because it can pose such a high risk for your pregnancy. So that is something you guys definitely should know. Substance abuse disorder. Um, what are our warning signs for a patient? Because a lot of patients are not going to come right out and tell you, like, yeah, I use meth every single day, right? We kind of have to use our context clues, use our assessment skills to figure out who's at high risk or not. Warning signs would be late or no prenatal care, if they're non-compliant to their treatment, if they have poor nutrition habits, if they're in continued legal and familial disputes, if they've previously had children and you ask them about like custody and they're either aloof or the answers they give you aren't very straightforward, sometimes that can indicate that there's something going on with Child Protective Services. So just we need to keep this in mind. We screen every patient during prenatal visits for the prevalence of drug use. Typically, it's at their first prenatal appointment during a urine test. We're going to test for everything. So, with these substances, they have their own complications with the baby with them. So, you guys should know what fetal complications can be seen with these different types of substances. So, with tobacco use, complications that can arise would be an ectopic pregnancy, a placenta previa when that placenta develops over top of the cervix, placental abruption, preterm rupture of membranes, intrauterine growth restriction, and low birth weight babies. Alcohol increases your chance of birth defects or like alcohol and syndrome. Marijuana, the biggest thing that we've seen so far, there has not been extensive research done on this, is intrauterine growth restriction. If a mom is on opioids continuously throughout her pregnancy, whether self-inflicted or medically prescribed, we see this baby have a lot of intrauterine growth restriction problems. A placental abruption is a really high risk. An intrauterine passage of meconium, so the baby has the first bowel movement while they're still in the womb, which is a sign of fetal distress, can occur. Preterm labor, fetal death. And then after delivery, we need to monitor this baby extensively for infant withdrawal. We're going to talk about that in the next couple weeks whenever we get to our newborn fetal assessment. But withdrawal can occur from opioids in the newborn. With cocaine use, we see preterm labor. A big one is placental abruption, preeclampsia, intrauterine growth restriction, low birth weight babies, and then small for gestational age infants. Methamphetamines, the biggest complication with that would be microcephaly, placental abruption, congenital malformations of the brain and the heart. Okay, so know those different things. So, how do we screen with the four Ps? What does that mean whenever we're doing a screening tool for the use of alcohol or any other type of substance during pregnancy? So, we ask parents, partner, past, and pregnancy. With our parents, we can ask the patient, did either of your parents have problems with drugs or alcohol? We can ask about the partner. Does your partner have any problems with drug or alcohol? In the past, have you ever had any beer, wine, liquor, or used drugs or street drugs? And in the month leading up to the pregnancy, how many cigarettes did you smoke? How much did you drink? So this gives us a good idea of the patient's social habits in general, and can kind of also screen for the risk of substance abuse during pregnancy. What are interventions for substance abuse during pregnancy? So we're going to educate the patient on the side effects for both themselves and the baby. We're going to stress about the importance of making sure that baby stays safe and that mom stays safe. Absent is the best course of treatment. Unless mom is using opioids, then of course we need to get on a withdrawal regimen. We cannot just tell moms to abruptly stop the medication or prescription medications that they've been on, because that can send them into withdrawal, and withdrawal can be extremely dangerous for a developing baby. Nicotine replacement therapy must be used cautiously, because we really don't want to be introducing anything in excess to what they're already intaking. Any patient experiencing withdrawal during detox must be monitored carefully in the hospital, like we said, because withdrawal and detox can be a very dangerous process in general without even taking into consideration if the patient is pregnant. Nurses are mandatory reporters. Legal intervention may be required. So that is also the case if you are taking care of a patient in the hospital and you suspect that she's either using drugs, there are drugs in the home, or that the partner is currently on drugs or taking drugs. You're responsible for calling and contacting social work at your hospital or escalating it and going to the police and child protective services, right? Because the number one thing is we want this mom to get help and be in a safe environment, but we also want this newborn to be in a safe environment. So it is part of our job to report anything suspicious. What are other nursing interventions with these patients? Um, we want to treat them with respect. Obviously, you're not changing your bedside manner simply because somebody is struggling with substance abuse. We want to talk to them and develop trust so that they are more likely to share with us what their typical regimen looks like, how much they're taking, when they take, um, and all that. So, developing trust and treating the patients with respect is mandatory. So, autoimmune collagen vascular diseases. So, this kind of goes into systemic sclerosis, antiphospholipid syndrome, rheumatoid arthritis, myasthenia gravis, and then lupus. So, we're going to talk more about myasthenia gravis and lupus because these are bigger ones that we see and they're more common. So, myasthenia gravis is going to affect your motor function, muscle weakness. So, if you have a patient who has an affected motor function, they're not going to be able to push as effectively as a patient who does not have myasthenia gravis and who does not have any impairment. So we need to be able to assist them into different positions that will aid them in pushing rather than just like encouraging them to push in a way that their body is not capable of. Mag sulfate, which is a medication that we're going to talk about that we give a lot of the times for preeclampsia, is contraindicated in these patients because it impairs the already slowed nerve muscle connections, and it can increase the patient's risk for respiratory depression. Excuse me. Systemic lupus is a multi-system inflammatory disease. With these patients, we need to know that it is linked with an increased risk of intrauterine growth restriction, preterm birth, stillbirth, miscarriage, and preeclampsia. So, moving on here to chapter 12, we're going to talk about our high-risk perinatal care, gestational conditions. Hypertension in pregnancy. We are going to talk about this a lot, and there's going to be a lot of questions about it on exam 2. So I want you guys to understand hypertension in pregnancy, like the back of your hand, because it is going to be something you see throughout the rest of this class. So we can break it up into chronic hypertension, gestational hypertension, preeclampsia with or without severe features, HELP syndrome, and then eclampsia. Okay, all of these have to do with our blood pressure, and these are all considered high risk during pregnancy. So, gestational hypertension, what are our parameters? This would be diagnosed as a patient who has a systolic blood pressure of greater than 140 millimeters of mercury, and then a diastolic blood pressure that's greater than 90 millimeters per mercury. It has to be recorded on 2 separate occasions, at least 4 hours apart, and the woman is typically diagnosed after 20 weeks of gestation with who's had a normal blood pressure in the past. Okay, so gestational hypertension, anytime you say the word gestational before that, before something, it means that this was developed in pregnancy. This is not a pre-existing condition. Okay, and it typically goes away after birth. Same with gestational diabetes. Typically, as soon as that baby is delivered, that mom does not need to check her blood sugars and does not need to be monitoring anything at home anymore or taking insulin or any type of med. That's the same thing with gestational hypertension. This is because hypertension in pregnancy is not something that is wrong with the vasculature, heart system, cardiovascular system, or function. This is directly related to the placenta. Your placenta, or a woman's placenta during pregnancy, is what is ultimately going to be causing hypertension, preeclampsia, eclampsia, HELP syndrome. So as soon as that placenta is delivered and expelled from mom, her blood pressure should go right back to normal. Okay. Now, is it uncommon to see preeclampsia develop after delivery? No, but we're going to talk about that because that is a separate instance and that's a separate case scenario. Okay. So know your normals and know your parameters for gestational hypertension, which would be a blood pressure, a systolic blood pressure over 140 and a diastolic over 90. We have to have 2 separate occasions with these high readings for it to be diagnosed, and it's typically diagnosed after 20 weeks of gestation. Chronic hypertensive disorders. So see how there's no gestational before these words. This means that this was hypertension that was present before pregnancy and it was diagnosed before 20 weeks of gestation. Gestational hypertension may be diagnosed as chronic if it persists after the postpartum period. So, what does that mean? If a mom's blood pressure does not resolve after pregnancy, it does not resolve after 6 weeks after she's received labetalol or other oral medication at home, then we are giving her the diagnosis of chronic hypertension. Okay. Preeclampsia. Preeclampsia is a progressive disorder with the placenta as the root cause of the disease. Okay. Therefore, the disease begins to resolve after the placenta has been expelled, like we talked about. The current thought is that the pathologic changes that occur in the woman with preeclampsia are caused by disruptions in placental perfusion and endothelial cell dysfunction. So, what does that mean? Most of the time, if mom's body is working to compensate for this extra blood supply and blood flow through the placenta, it can cause her to start developing preeclampsia or start to develop gestational hypertension. These changes develop early in pregnancy, long before signs and symptoms of preeclampsia become evident. So, what happens in a normal pregnancy, right? We have to know our normals before we can diagnose something as abnormal. So normally in pregnancy, the spiral arteries in the uterus are going to widen from thick-walled muscular vessels to thinner sac-like vessels. This allows them to handle the increased blood flow and blood volume of pregnancy, right? Because we have an increased amount of blood volume by 40 to 50%. So our body is pumping a lot more blood and working and compensating for an increased amount of blood volume. Because this vascular remodeling does not occur or only partially develops in women with preeclampsia, decreased placental perfusion and hypoxia are going to happen. So, if mom's body is not naturally adjusting the vasculature to compensate for the increased amount of blood volume and the increased amount of blood flow, it's going to result in constriction, it's going to result in hypoxia and decreased placental perfusion, which is going to cause her to have gestational hypertension or preeclampsia as a result. Okay, this poor perfusion as a result of vasospasm and reduced plasma volume is going to cause that increase in blood pressure. Okay, so you guys definitely need to understand that concept. Understand what is normal in pregnancy. How does that body compensating for the blood volume, the excess amount of blood volume that we're producing, and what can occur if it does not? One of the things that can occur is preeclampsia. What puts a mom at higher risk for preeclampsia? If this is her first pregnancy or if she's never had a baby before, if she's pregnant with twins or multiple babies, if she has a history of preeclampsia in a previous pregnancy, if she has underlying chronic hypertension, if she has pregestational diabetes, thrombophilia, if she's obese with a BMI over 30, a maternal age over 35, and if she has underlying kidney disease. This is all going to increase a mom's risk factor for preeclampsia. What are our associated problems? So, increased blood pressure, obviously, with preeclampsia, we typically see moms have those sustained high blood pressures. We are going to see a decrease in kidney perfusion. Okay, so mom is going to urinate less. She may have a little bit more swelling, and edema, and extracellular fluid increase as a result. She'll have headaches, hyperreflexia. So her reflexes are going to be not just +2, they're going to be +3 or +4, super hyperreflexic. Positive ankylosing, and then in severe cases, moms, if her blood pressure is left untreated and elevated for prolonged amounts of time, she's at a risk for developing seizures. Okay. So this picture over here is really good because it shows you your signs and symptoms. Okay. It also talks about our risk factors. A group of patients that is at a high risk for preeclampsia is the African American population. And that is because, in general, African Americans that are a higher risk for developing chronic blood pressure. So they're already at a high risk for developing blood pressure, especially if they have a pertinent family history of chronic hypertension. So these women should be monitored very, very cautiously, both before, during, and after their pregnancy. What are our prevention methods? So, how do we prevent a woman from developing preeclampsia, right? There have been many studies conducted on various vitamins and interventions to lower the chances of a woman developing preeclampsia, but the only medication that we've seen to be proven and proven it to be effective is low-dose aspirin. This medication could be started around 12 to 28 weeks in a woman with high risk factors. There's currently no biomarker or screening tool available to identify women who will develop preeclampsia. Okay. Maybe someday we'll be able to pick up on something that is flagged earlier in women with preeclampsia, but for now, there is no early indicator. So, who would be the women that we would tell to take low dose aspirin at that 12 weeks? That would be your chronic hypertensive moms. That would be your moms that have pregestational diabetes. Your obese moms can sometimes be given low dose aspirin prophylactically. So, those are some patients that need to potentially start up aspirin earlier. Assessment. How do we assess for preeclampsia? How do we know if a mom is developing preeclampsia? We talked about her signs and symptoms. We talked about her clinical manifestations a little bit, but let's talk about what the actual assessment of a mom with pre-E is going to look like. So, first thing, we need to get accurate blood pressures. Okay, so if you put the wrong size blood pressure cuff on a mom and it gives you a reading that looks awesome, it's like 120/80, and then it's 2 times the size of the patient, you need to get a cuff that fits your mom to make sure that it's reading the blood pressure accurately. If you get an elevated blood pressure, we need to have two back to back within 15 minutes of each other to diagnose them as having chronic hypertension or preeclampsia. Edema. These moms are going to have some serious edema in their lower extremities, and it's usually pitting. It's usually pretty painful. and it's been developed for a while, or if it's new onset, that would also be startling and something we would need to look into. Their deep tendon reflexes, we need to assess those because they usually are typically hyperreflexic with preeclampsia. Clonus, we need to be assessing for presence of clonus or absence of clonus. Proteinuria. So moms run the risk with preeclampsia because of the way this disease process works of having protein in their urine or protein spill into their urine. This can be an indicator that they are developing or have preeclampsia. So, in a 24-hour specimen, proteinuria is defined as a concentration at or greater than 300 milligrams or a PC ratio greater than 0.3. PC ratio means protein creatinine ratio. We talked about with preeclampsia that one of the things that is damaged in this disease process are the mom's kidneys. Okay. So if there's kidney damage, mom is not producing as much urine. She has this excess edema. Her blood pressure is elevated. Her body is going to start compensating. Her protein is going to start spilling into her urine. There's going to be other microbes, glucose, other things spilling into her urine because she's not excreting as much. Her glomerular filtration rate is going to be not as effective. Her kidneys are going to take a hit, so her protein creatinine ratio is going to elevate. If we see a PC ratio greater than 0.3, that is an indicator that that mom is developing or has preeclampsia. So think about it as a whole systemic look at the big picture. If her kidneys are failing because of this preeclampsia, because of the way that this vascular system has not adjusted for this disease process, we're going to see that result in a protein sample, in a urine culture, or a protein or a urine specimen. Okay? But for your purposes of your testing, I need you to know that a PC ratio at 0.3 or greater is an indicator that the mom has preeclampsia. Neurological changes. So that goes on to along the lines of like mom is developing a headache. That doesn't go away with Tylenol. She has that blurred vision. She's dizzy. She's not feeling very well. She's um, having a hard time concentrating more than normal, right? This isn't just like pregnancy brain that we're talking about. Um, she loses consciousness. She has seizures. Okay, that's what we talk about whenever we're referring to neurological changes. Okay, so let's go back to this previous slide. I want you guys to know these signs and symptoms really, really well. The headache, visual changes, nausea, swelling of the hands and feet or face, shortness of breath, or loss of consciousness, okay? Because that is also going to help you understand why we're looking at the lab values that we're going to look at for preeclampsia. Something that is kind of related to all of our hypertensive issues is HELLP syndrome. So this is a variant of preeclampsia, okay, but they have specific markers and specific things that we look at to diagnose HELLP syndrome that are slightly different than preeclampsia. So it's diagnosed by specific lab values. It can occur in women without hypertension or proteinuria. So this does not necessarily go hand in hand with elevated blood pressures or abnormal results from a urine culture or urine specimen. So patients with HELLP syndrome have an increased risk of maternal death, pulmonary edema, acute renal failure, DIC, placental abruption, liver failure, sepsis, or stroke. So this is a big deal. Okay, we listed like all of the big bad scary ones. So hemolysis, they're going to see your elevated liver enzymes and a low platelet count. So what does this mean for your test? What do you need to know? You guys need to know your normal lab values, okay? You're going to hear that all the way through nursing school. You're going to hear that as a bedside nurse. Know your normals. What is a normal liver enzyme? What should an AST or an ALT be? Okay, you need to know that. What is your normal platelet count? What would a low platelet count look like? Because you might have a question on your exam that just gives you an example of here's a mom's lab values. What is this telling you? Or how should you treat this? Okay, so this is HELLP syndrome. Like I said, this is a variant of preeclampsia, but it's diagnosed by these specific lab values, and this HELLP spells out what you guys need to remember for it. So, Anytime we talk about gestational hypertension and preeclampsia, we can define it as with or without severe features. So, gestational hypertension and preeclampsia without severe features could be mom has an elevated blood pressure, but she does not have protein in her urine. She is not having deep tendon reflex issues. She's not showing signs of any clonus or any neurological deficits. She simply has the high blood pressure. Her lab values are normal, but she has some pretty severe pressures. Okay. Gestational hypertension and preeclampsia with severe features are going to be you have more than one diagnostic feature for this mom, and she's experiencing more than one clinical manifestation of hypertension or preeclampsia. So, that is an elevated blood pressure of severe range. That would be 160 over 110 is severe range blood pressure. That's different than your diagnostic standard for gestational hypertension, which is 140 over 90. So severe blood pressure, when we're talking about we need to be giving magnesium and labetalol and doing all our interventions, is going to be 160 over 110, and you're getting those readings, two readings consecutively within a 30-minute time frame. Okay. As nurses, we're going to be treating patients differently based on their clinical symptoms and lab values. We need to assess our patient and not our monitors. Okay, so what is our treatment going to look like? Without severe features, the goal of treatment is to progress the pregnancy as long as the fetus will allow, and most likely schedule an induction around 37 weeks or the following week if the infant is tolerating pregnancy and everything still looks fine. So, if a mom has elevated blood pressures without severe features, no other underlying lab values are weird, she's not complaining of a headache, upper gastric pain, right upper quadrant pain, nothing crazy, we let that pregnancy go as long as that infant is going to allow. This mom might have an OB visit twice a week, though. She's high risk. So we need to be monitoring her very closely. This mom also might be a mom that we're giving her education on how to take her blood pressures herself at home. So it's pretty serious at this point. We need her to monitor pretty closely. Management will most likely take place at home. Patients should be educated on signs and symptoms to call the doctor. So, like that high home blood pressure, dizziness, epigastric pain, blurred vision, drastic increase in swelling, decreased fetal movement. All of those things we need to tell our patient about. If a mom has gestational hypertension or preeclampsia with severe features, the patients are hospitalized and they're going to receive alternative treatment. So these are moms that as early as even 28 weeks, if they have really elevated blood pressures, they have protein in their urine, they're having neurological deficits or neurological changes, these moms are probably going to be hospitalized, and we're going to be treating this pregnancy very, very, very carefully. Because, like we said, all of this is stemming from that placenta. So as soon as that placenta is delivered, we should see a drastic decrease in her symptoms. So these patients who have severe features, who are being hospitalized, who are being managed in the hospital, what does that entail? So it depends on the gestational age. Anyone earlier than 35 weeks should be at a facility with high-risk maternal and fetal care available. This is not the patient that's going to deliver at my 10-bed LDRP, right? We are just simply not equipped for this kind of patient. We are going to administer corticosteroids to the mom for fetal lung development. The gold standard medication that we give is betamethasone. Okay, so betamethasone is administered in two different doses, 12 hours apart. Each dose is going to be a 6 milligram IM injection. This is to help with fetal lung development. So your infant, your fetus starts developing what's called surfactant as early as 24, sometimes earlier, weeks gestation. Surfactant is the material in the lungs that helps facilitate the expansion of the lungs during inspiration because it keeps the alveoli at the base of the lungs basically lubricated to allow for an easy opening and closing. That facilitates that oxygen and carbon dioxide exchange, which results in the appropriate oxygenation of our baby. If surfactant is not fully developed in a fetus, that can lead to respiratory distress, respiratory failure, metabolic acidosis, hypoxia, all that stuff. And that's when you see babies who need to be intubated. They go to the NICU, they're on a ventilator, and it's helping them breathe for the first week or so, 2 weeks, however long they need of their life. So we are going to give these corticosteroids prophylactically in any mom that's earlier than 35 weeks of gestation because it speeds up fetal lung development. We are going to continuously monitor this patient until symptoms subside and the patient is stable or until the delivery of the baby. Okay. So sometimes a mom could come in complaining of high blood pressures. She's having the neurological deficits and they give her some medication. It stabilizes. Sometimes moms can go home if the baby looks okay and they're comfortable with the medication regimen. Other times, mom will stay in the hospital receiving magnesium until she's delivering. Other times, they just need to deliver the baby if it's severe enough and if that baby's in distress. If delivery is imminent or clinical symptoms have reached dangerous levels, we're going to manage differently. Okay. That typically means that we're going to be delivering this baby at a high risk facility where there's NICU available and there's a neonatologist close by. How are we going to change the way that we manage labor on a patient who is preeclamptic? Because there are some things that we are going to need to do differently. Okay. So, these patients are going to be monitored very, very, very closely. So, continuous vital sign management. So, we're going to be watching their blood pressure. If we need to give them medications, we're going to be administering medications, which we are going to be talking about here in the next couple slides. Okay. Mag sulfate therapy is the number one thing that we use whenever there's a patient who's preeclamptic with severe features or who has uncontrolled chronic hypertension. Okay. Blood pressure management and control is essential. The other thing with these patients is we want to reduce the amount of external stimuli as possible. So we are going to dim the lights in this patient's room. We're ensuring a quiet, non-stimulating environment. We're going to educate the patient on the side effects of the medication and their labor process, how that's going to look. We're going to initiate seizure precautions. So we're maintaining a very quiet environment for these patients. Not necessarily because like they just need more rest. No, it's because of the neurological deficits that they're at an increased risk for. If your patient is at an increased risk for having seizures, we do not want the lights super bright. We do not want flashing lights or anything that can instill an episode. So these seizure precautions are also things that we're going to use. We're going to pad the side rails, have suction equipment available. Their oxygen mask needs to be hooked up and available immediately, and then a call button in reach. We need to have emergency meds at the bedside. Um, Sometimes with preeclamptic patients, if they're dizzy enough, if they're disoriented enough, or if they're receiving magnesium and their motor function has decreased, these patients may need a Foley or we need to initiate an alternative toileting plan because we don't want them to fall, right? These patients can be at an increased risk for falls. We need to also educate our support person on when to call out in an emergency. So, educate that support person of what is it going to look like if your partner has a seizure. If your partner starts displaying these signs and symptoms, or they say, or they start to not make very much sense, or they seem like they don't know where they are, hit this big red button because we need to know about it immediately. And then you guys should know your nursing action during a seizure. We're laying our patient on their side. We're making sure that the airway is clear. We're going to have suction readily available. We're activating a rapid response so that we can get providers in the bedside. Administering oxygen if necessary, and just making sure that the patient is safe in an area where they're free from anything that's going to cause them further injury. Time our seizures. We want to know when it starts and when it ends so we know how long it is. And then we're monitoring that patient extensively after the seizure as well. Okay, so we talked a lot about high blood pressures. We talked about a lot about preeclampsia, signs and symptoms. Now let's talk about common treatment for high blood pressure and preeclampsia. The number one thing that we're going to talk about with this is mag sulfate therapy. So, this is the medication of choice for preventing and treating seizure activity. It is usually administered IV, intravenous. We need two large bore IVs whenever we're administering magnesium because hardly anything is compatible with magnesium. Okay, so we need to have a separate IV site in case we have to give the patient blood or in case we have to give them some other type of antibiotic or something that is not compatible with mag. Magnesium, once it's initiated, it is intended to be a continuous IV drip. This is something the patient is going to be receiving typically until delivery of the baby, if not for for 24 hours or longer after the delivery of the infant. Magnesium is administered with an initial loading dose of a 4 to 6 gram bolus, which is infused over 15 to 20 minutes. Okay. The entire time you're administering that IV bolus, a nurse has to be at the bedside. A primary nurse has to be at the bedside with the patient. The maintenance dose after that initial bolus is reduced to about 1 to 2 grams an hour. And then the dose should maintain therapeutic serum mag levels of between 4 and 7. Okay. So these patients are getting routine magnesium draws, okay, to assess for toxicity. Okay. The reversal agent for magnesium sulfate is calcium gluconate, which you need to have present at your bedside if you're going to be administering magnesium. Magnesium, so what is helpful when we think about the disease process of hypertension or preeclampsia, right? Magnesium is going to help relax the smooth muscle or the vessels in the wall that are restricted and constricting and cutting off blood flow to the placenta, and everything is just constricted because of the disease process itself. Magnesium is going to help you relax that smooth muscle and help dilate those vessels to help lower our blood pressure. Okay, so that is why we're administering mag, and that's why it's on a continuous IV drip, because typically we need to have that placenta delivered before we see a resolve in the blood pressures. Okay, so mag is a really good go-to for long-term blood pressure treatment or management in labor. There are some things that we need to know specifically about magnesium and the administration of magnesium because it is a high alert medication. So, what does that mean? We need to have 2 nurses verifying whenever this is initiated at the bedside. So, you need to grab a friend anytime you're starting magnesium and you're like, all right, Susie, I got to go get my mag bolus on this patient. She's preeclamptic. She has severe features. We need to get this mag started right away. So you need to have your friend come with you. It causes relaxation of the smooth muscle, so it occasionally leads to uterine relaxation. So what does that mean? If a mom is in labor, this can sometimes get rid of her contractions because it's causing that systemic relaxation of smooth muscle, and it leads to that. It can also cause your uterus, which is a muscle, to relax. So oftentimes we need to run oxytocin with magnesium for labor. We need to give the mom more contractions as well as relax her smooth muscle to prevent her blood pressure from being too high. So magnesium kind of counteracts natural labor progress. Okay. It's continued in the postpartum period, typically for 24 hours, especially on your high risk moms. You need to know, star, circle, underline, write it on your ceiling. You need to know these symptoms of magnesium toxicity. Okay. How do we know if a patient's magnesium is too much? She's getting too much magnesium. She does not have deep tendon reflexes. They're completely zero. Her smooth muscle is relaxed to the point that she is not having any reflexes at all. Decreased respiratory rate, right? Magnesium can cause respiratory depression. So we need to be monitoring patients' vitals very closely. And then decreased level of consciousness is another one. So has your mom lost consciousness? She passed out? Is she not responsive? Anything like that, we need to administer our calcium gluconate. We need to stop our magnesium infusion because she is having a adverse, dangerous reaction because she's having mag toxicity. What else do we need to do? We need accurate I's and O's. So you need to know what your hourly urine output should be minimally, and that's 30 mLs an hour, right? So why would we have decreased urine output? Because this is affecting our kidney function, right? Preeclampsia, hypertension is affecting our kidney function. We can see decreased urine output with this medication. Magnesium itself can cause systemic dehydration and lead to decreased urine output. Okay. We need to keep the patient in bed. This is dependent on your facility. The facilities that I've worked at, we always keep our patient in bed. We put a Foley catheter in every patient, but we also aren't running magnesium or managing magnesium. We're typically shipping these patients out to a bigger hospital. So it depends on how sick your mom is, really. If mom is bedbound, we need to be changing her position frequently. Vitals should be every 15 minutes with these patients. During our bolus of MAG, the nurse has to stay at the bedside and perform a focused assessment every 5 minutes. What is your focused assessment? Respiratory rate and vitals, your deep tendon reflexes, level of consciousness, lung sounds. Okay. Um, we need to titrate IV fluid with MAG per provided order because we usually are not going to give these patients no more than 125 mLs an hour. So these patients are on a fluid restriction because the magnesium itself and the way the medication works can sometimes cause a fluid volume overload. Your mom is already edematous. Her blood pressure is already elevated. We're having kidney renal dysfunction. So we need to monitor the amount of input that we are having as well as the amount of output that we are receiving back, right? Lung sounds are important to assess because if she starts having like crackles in the bases of her lungs, we're filling her lungs with fluid. Something is happening. She's in fluid volume excess. We do not want pulmonary edema, so we need to notify our provider about that immediately. Okay. Level of consciousness, proteinuria, deep tendon reflexes, headache, visual disturbances, epigastric pain hourly. We need to be doing those assessments. And then obviously, the entire time you're doing any of this, you need to make sure you have your baby on your monitor. So, um, what is our immediate blood pressure management? Okay, so magnesium, that medication is great for a long-term management of a patient that we are laboring or a patient who comes in with preeclampsia with severe features who may need uh, management during labor to protect not only the fetus, fetal development, but also mom from seizures. So magnesium is typically given to reduce the mom's instances of seizures. And assist with neonatal brain development. Whereas there's other medications that could be better to give if mom comes in a hypertensive crisis. So these are medications that are administered when the blood pressure is greater than 160 and the diastolic is greater than 110. The table on page 290 is going to be your go-to as far as like side effects, when to administer, how to administer, all of that. We're going to just talk about the big ones that we see. Treatment is administered immediately to prevent long-term complications. So these are the medications that we're giving a mom that first comes into the unit who has elevated blood pressures. How are we going to decrease these blood pressures in quickly? Hydralazine, labetalol, and nifedipine. Typically, I see providers order labetalol IV push because it's the fastest acting, it's the most effective. Hydralazine is typically given second. Nifedipine or Procardia is given only if the mom does not have an IV because Procardia is only given as an extended release oral tablet, immediate release oral tablet. So these three are the ones that we're going to give in a blood pressure or a hypertensive crisis. Okay, these are specifically only given to lower your blood pressure. Magnesium is given not only to help with blood pressure management, but also to prevent moms from developing any seizures or underlying neurological deficits, and also to help assist with neurological brain function of the newborn. Okay, so that's the biggest difference between these three medications and our magnesium. So you guys need to know these three for sure. Moving on here. So we talked about gestational hypertension, chronic hypertension. We discussed preeclampsia. We went over HELP syndrome. The last one on our list as far as hypertensive crisis goes is eclampsia. So this is what we call it whenever a woman has a seizure or a coma in a preeclamptic patient. So it is preeclampsia in a patient until she has a seizure. As soon as she has a seizure, that patient is eclamptic or has eclampsia. Okay. You cannot have eclampsia unless the patient has had a seizure or another type of major neurological event. This is typically preceded by symptoms but can occur in women with absent hypertension, no proteinuria, and no edema. That's not as rare, but it can happen. Symptoms before, so some things that patients have complained about in the past have been persistent occipital headaches, blurred vision, photophobia, epigastric pain, or altered mental status. Okay. Eclamptic seizures are typically the tonic-clonic seizures, which I have a picture over here. The tonic, so you have the tonic phase, um, and then you have the clonic phase where they're contracted and they're having those rigid movements. Okay. Um, Typically after a seizure, we see mom or patients that are hypotensive, disoriented. They don't remember having the seizure. They don't remember sometimes where they are, very disoriented. So, what is our management as nurses before, during, and after? So, before a seizure occurs, obviously we're assessing the patient. At this point, it's typically if a patient comes in and they're just like, I haven't been feeling the best. I don't know what's going on really. Sometimes, like, I just have these terrible headaches. We're going to ask them their interview questions, their admission questions. If they're having symptoms and history of seizures, we need to initiate those seizure precautions that we talked about. During a seizure, our patient safety is the priority, right? So we're going to turn the patient on their side, make sure that they have a patent airway and maintain a patent airway, move anything sharp from near the patient, call for help, stay at the bedside with the patient. And then afterwards, we're assisting with patient stabilization, right? So we're going to assess the status of the airway and administer oxygen or intubate if needed. We need to activate that code or rapid response, which really should be done during, if possible. Suction out secretions from the patient's mouth, place an IV if there's not one yet. Administer magnesium. Why are we administering magnesium? Not for hypertension, to reduce our risk for developing seizures. Or increase the dose. If the patient's already on magnesium, it's not as therapeutic as it needs to be if they're seizing. So we need to increase our magnesium dose. If another seizure occurs after or immediately after, we need to administer 2 milligrams of IV lorazepam. And then obviously you're assessing your baby's status. Okay, so that concludes our major points that we want to talk about as far as hypertensive disorders during pregnancy. So you guys definitely need to focus a lot of your time on studying chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and HELP syndrome. Understand why magnesium is given versus why labetalol, nifedipine, and hydralazine are given, right? Those three medications are given specifically for blood pressure management, whereas magnesium is given not only to assist with blood pressure management, but also to prevent seizure activity or neurological deficits in the mom and assist with newborn brain development. Okay, so let's move on. We're going to talk about hyperemesis gravidarum. I had briefly mentioned this in week 1 or 2 whenever we were talking about common occurrences during pregnancy. So, this is the most common reason for hospitalization in the first half of pregnancy and the second most common in pregnancy overall. Hyperemesis gravidarum is your nausea and vomiting that you can see in pregnancy, but escalated by 100. So, what do we see with these patients? So, these are the patients who they are not able to keep anything down. They're not able to drink water without getting sick. They are not able to eat saltines without getting sick. They can hardly even change their position in bed, go from standing to sitting up without having uh, an episode of vomiting. This takes nausea and vomiting up to a whole new level. So when patients are say like, "Oh, I'm a little nauseous," or "I have morning sickness really bad," but then it goes away after I eat some protein, or it goes away after a couple hours. Patients with hyperemesis gravidarum, it is consistent, it is constant, it does not go away. There's nothing really that they can do to um, help with this. So, what do we see with these patients? We see excessive weight loss to a dangerous level, um, ketonemia, electrolyte imbalances, and dehydration. That is the thing we are worried about the most with these types of patients or patients that present with this. Um, are the dehydration and the electrolyte imbalances because it can be very dangerous. Nutritional deficits are we're going to see with that as well because they're not having an adequate source of intake. Treatment would be antiemetics, IV fluids, measuring ins and outs, oral hygiene, and diet. Okay. Moms need to avoid an empty stomach. So we're telling them eat small, frequent meals, dry, bland, high protein meals. They should have their protein after sweets. Cold is typically better than warm. And then alternate fluids and solids. Okay. This little graph here shows you the differences in a normal pregnancy versus hyperemesis gravidarium, and then things they both have in common. We're going to be going over this in class, so I'm not going to talk about it right now. So let's move on here. Another high risk thing that we have to take into consideration whenever we're talking about antepartum care is early pregnancy bleeding. Some things that we can see in the first trimester um, that can be dangerous, that can be life-threatening for moms and obviously for the fetus. So first, we're going to talk about a miscarriage or spontaneous abortion. This is defined as something that happens before 20 weeks, right? We talked about our gravity parity term, preterm, all of that. So we know anything after 20 weeks, we consider it to be a stillborn. Anything before 20 weeks, we consider that to be a miscarriage or an abortion. So early miscarriage or spontaneous abortion happens before 12 weeks. Late would be 12 to 20. There are different categories of miscarriage. There's threatened, inevitable, incomplete, complete, missed, and septic. So you guys can read about the different types in your books. We're just going to talk about big picture here. Medical or surgical management is going to have to happen sometimes once confirmed. If it is an early indicator of a miscarriage or it's a spontaneous abortion or spontaneous miscarriage earlier than 12 weeks, sometimes moms will pass the fetus on their own, okay? And they don't need medical or surgical management. If it's diagnosed and that baby has not been passed yet or the fetus has not been passed, sometimes we can give a medication called Cytotec to hasten the process if mom's desire. That is completely mom's choice and up to the provider if they think it is safe. Surgical management would be a DNC. Okay, so a DNC is dilation and curettage, where they go in and they basically remove the products of conception from the uterus, effectively giving a woman a period is what is happening. So it is a miscarriage, but it's also restarting the woman's cycle as well. Okay. Cerclage for cervical insufficiency. So what that means is if a mom has had a history of multiple miscarriages early or sometimes even late, like that 12 to 20 week period, providers will go in and they will surgically stitch the cervix closed to prevent the cervix from opening and prevent moms from going into preterm labor. Okay, so the DNC cytotech and cerclage for cervical insufficiency, this is typically, like I said, if a woman has had a history of second trimester loss or recurrent miscarriages. When we talk about cervical insufficiency, let's define that. That's the passive and painless dilation of the cervix leading to recurrent preterm birth. Okay. So we need to know for like medical or surgical management, we're talking about a DNC mostly. If we have to go in and surgically remove products of conception, or a cerclage, which is that stitching of the cervix closed to prevent preterm labor. What is an ectopic pregnancy? We talked about this briefly whenever we were going over the menstrual cycle. It is a fertilized when it is whatever happens when a fertilized ovum is implanted outside of the cervix. Okay, so this could be like it's implanted in the fallopian tube, it's implanted into a different area of the body altogether. Medical or surgical intervention is necessary for these because they can be life-threatening, like we talked about earlier in class. If the fertilized ovum begins to grow and develop in the fallopian tube, and then it gets too big, it can rupture that fallopian tube. Mom can hemorrhage. We lose a fallopian tube, thereby losing access to an ovary and egg production. So it can be life-threatening for the mom. So it's managed with a medication called methotrexate if discovered early enough. Methotrexate will terminate the cells developing, which causes the pregnancy to be absorbed within the next 4 to 6 weeks. Okay, so methotrexate is a medication that will just basically dissolve the pregnancy. Otherwise, surgery is needed depending on how big the developing entity is and where it is. Occasionally, removal of one or both fallopian tubes is necessary with an ectopic. Okay, a molar pregnancy as the benign growth of placental cells into which the chorionic cilia develop into edematous, cystic, avascular, transparent vessels that hang in a grape-like cluster. Those are a lot of fancy words. I'm going to show you a picture on the next slide, okay? Surgical intervention. So for a molar pregnancy, we do a DNC, okay? We have to go in and evacuate and excavate all of that. So let's look at this slide because there's some good pictures. All right, so over on the left here, this is a picture of a cerclage. That is the little band or the surgical incision or the surgical stitching that a provider will go in for a mom who has that cervical insufficiency to prevent preterm labor. Okay. Here we have an ectopic pregnancy, so you can see that ovum is developing in the right fallopian tube, in the woman's left fallopian tube, I mean. So this can be dangerous because, like we said, if this gets too big, it can cause fallopian tube rupture, cause hemorrhage, and place the mom at an increased risk. Here is a picture down of here of our molar pregnancy, which are those little like clusters that are developing. Okay, it's placental tissue effectively that's just developing and it's abnormal. So we need to go in and do a DNC, which is that dilation and curettage, and remove all of that from the uterus. Okay, so here is the different classifications of spontaneous abortions. You guys can review that on your own. Um, and you can go into it more extensively in the text, okay? So we talked about early pregnancy bleeding, the spontaneous abortion, ectopic pregnancy, and a molar pregnancy. Let's talk about what happens whenever we see late pregnancy bleeding. These are typically attributed to a placenta previa and a placental abruption. So, what is a placenta previa? You guys have heard me say this word and this term a lot. So, we're going to actually show you what it means now. This is what happens when a placenta is implanted in the lower uterine segment so that it either completely or partially covers the cervical os. So here's a picture here. Okay, so on the left we see a normal placenta. That would be posterior. Okay, that's normal. That's adhered to the endometrial lining of our uterus. It's in the back. The baby is going to be head down first. Head is directly over the cervix. Marginal means that this is growing like right by the baby, close to the opening of the placenta, close to the opening of the cervix, but not completely covering the cervix. It's just really close. Okay. And then a partial. That you see how that edge of the placenta is coming down into the cervical opening over that cervical os. That's a partial placenta previa. And then a total previa. This placenta is completely covering that cervical opening. And that's dangerous. We'll talk about why. So the main complication is hemorrhage. And a hysterectomy. Okay. So if mom delivers and is bleeding and bleeding and bleeding and bleeding because of this placenta previa, um, these patients have to deliver via C-section. Placenta previas, if you have a placenta over the cervical opening, you cannot safely labor because we run the risk of this placenta abrupting off of the uterine wall and being delivered before the baby. And your placenta is your baby's oxygen, right? So if the placenta is completely abrupted off of the uterine wall, we're not going to have that exchange and transfer of blood and oxygen, and that baby is going to die. So we cannot deliver vaginally if a mom has a placenta previa. Um, so this is delivered C-section at or above 38 weeks. We don't typically let them go all the way to term because we don't want to run the risk of them going into spontaneous labor. Okay. We worry about preterm birth and IUGR. Typically, if we have a mom with a placenta previa, she can start having contractions and start going into labor earlier than moms who do not have a placenta previa. So these are things we need to educate our patients on. What are those signs and symptoms of preterm delivery, right? Clinical manifestations. These moms, you're going to see that painless, bright red vaginal bleeding during the second or third trimester. Okay. So if moms have a complaint of bleeding later in the second or third trimester, we need to definitely have them come in to be evaluated. So educate our patient when to come to the hospital. If she's having any contractions, if she's not feeling her baby move, if she's having that bleeding. No vaginal or rectal exams. The reason for that is if you put your fingers up a vagina and the placenta is the presenting part of the cervix, you run the risk of causing a placental abruption. Okay. For rectal exams, it just added pressure down below in the perineum, which can ultimately lead to preterm labor. We need to observe these moms closely. Once a placenta previa is diagnosed, these moms are seen on a weekly basis because we need to do repeat ultrasounds to make sure everything is progressing correctly. Um, and they're being monitored very closely. A placenta previa is an OB emergency. If a mom comes in who has one, odds are, and she's in labor, we need to go back for a C-section pretty rapidly. The next thing we're going to talk about is the placental abruption. So, a placental abruption is the premature separation of the placenta. It's detachment of part or all of a normally implanted placenta from the uterus. So we have a picture here. We see the placenta, it's nice and snug up against that uterus. An abruption is when that placenta starts to deliver or peel away from the uterus before that baby is safely delivered. Okay? Risk, maternal hypertension. So, what kind of things can cause a placental abruption? If a mom has high blood pressure, that can cause a placental abruption. Cocaine use can cause placental abruption. Um, Tobacco use, motor vehicle accidents, or any type of trauma to the abdomen, so like domestic violence, blunt force trauma, anything like that. What are we going to see, or how is this patient going to present? They're going to have some bleeding, abdominal pain, uterine tenderness, and then contractions. They're also going to have like when we say abdominal pain, it's not just like, oh, my belly kind of hurts. It's like these patients are writhing in the bed and they're having unrelieved, constant abdominal pain. Okay. Their belly is going to be tender to touch. Like a normal pregnant belly, like a normal mom, you should be able to go up and touch her belly, and she should be okay with that. It shouldn't bother her. In a placental abruption, any touch on the outside of her stomach is going to be excruciating. Um, the mom and baby outcome. So the prognosis depends on the extent of the abruption, the amount of blood loss, and the length of time. Okay. If a mom comes in right when she starts having these symptoms, odds are we have an emergency C-section. Baby might need some extra resuscitation because if that placenta has started partially abrupting from the uterine wall, we're going to have a disruption in fetal oxygenation, which can cause fetal distress at delivery. But if they come in relatively soon at the onset of the abruption, they have a pretty good chance of everything being okay. However, if a mom comes in who these symptoms have been going on for a long time, she's been bleeding all day, she's been at work and hasn't been able to come in, we run the risk of fetal demise and maternal potential complications for mom as well. So if mom is 20 to 34 weeks, we attempt to stop the bleeding if she comes in, and if possible, and the mom will be kept under observation. But if she comes in and is having any type of these symptoms and she's anywhere near term, then we need to deliver the baby. Okay, cord insertion variations. This is another thing that can consider or deem a mom to be high risk. So, a vasa previa is when the fetal vessels lie over the cervical os. The vessels are implanted into the fetal membranes rather than into the placenta, and usually these vessels are protected only by the membrane. Thus, they are at risk for rupture or compression. So, what can cause a vasa previa? SROM or traction on the cord can rupture fetal vessels. So, if a provider is pulling really hard on an umbilical cord after it has been delivered, or at whenever the provider or whenever the water breaks, it runs the risk of rupturing the vessels for the placenta. Um, we're at a risk for rupture or compression with this one. Okay, a filamentous cord insertion is a variation of vasa previa. Let me see. The vessels begin to branch at the membranes and then course onto the placenta. So it just is a different way that the umbilical cord is inserted into the placenta. A secentoriate placenta is when the fetal vessels run between placental lobes. Okay, so when the placenta is divided into two or more lobes rather than remaining as a singular mass. Okay, let's move on and talk about disseminated intravascular coagulation, or you guys should have already heard of this. It's called DIC. Okay, DIC is an acquired syndrome characterized by intravascular activation of coagulation, which becomes widespread rather than localized and results in excessive clot formation and hemorrhage. Okay, so this is never a primary diagnosis. It is a result from some event that has triggered this coagulative response. In the case of maternal and labor and all the stuff that we talk about in this class, the most common cause is a placental abruption. So if a mom has had a placental abruption, she is at an increased risk for developing DIC. Okay, this is life-threatening. You guys should have heard about this too in your A&P class. Um, but we're going to talk about it here in regards to maternal medicine. So, page 308 and box 12.6 has the physical exam findings and labs that can go alongside of DIC. This is a consumptive coagulopathy. So, you guys need to know what are the signs and symptoms of your patient. What does that mean? Um, so, sometimes it can be pathological and it's consuming the clotting factors. It causes widespread external and internal bleeding. So this can be in IV and injection sites, hematuria, so blood in the urine, petechiae, tachycardia, and diaphoresis are some things that we can see. It's an overreaction of the clotting cascade. What is our management of DIC? We need to correct the underlying cause. We need to stop whatever that initial reaction was. So we can give volume expanders, rapid replacement of blood products, and clotting factors. We need to make sure this mom is being very well oxygenated because she's constantly in this cycle of bleed, hemorrhage, clot, hemorrhage, clot, hemorrhage, clot. So we need to make sure that she's getting adequate oxygen to supply the red blood cells that are going through all these changes. We need to make sure that mom has a normal body temperature and reassess labs continuously. Okay. These patients go to the ICU. Okay. DIC patients are very, very sick and they ultimately need a lot of blood replacement, continuous hemodynamic monitoring. They are a 1-to-1, sometimes a 2-to-1 patient assignment. These patients are very sick and run the risk of dying. So we need to be very careful. Infections during pregnancy. We've talked about before the STIs, UTIs. So I want you guys to review these. There's not really anything additional besides what's on this slide that I wish to add. Group B strep we're going to talk about because it's only prevalent typically during pregnancy is the issue when there's an issue with it. Group B is a normal bacteria flora that lives in the vaginal canal, and it's normal. Women have that routinely, but it can be harmful to the babies. So we need to make sure and test for the prevalence of an increased amount of group B in the vaginal canal. So we do a swab at 35 weeks of gestation. It's a swab that starts at the opening of the vagina down to the rectum, an opening of the rectum. This develops over time and it's not present in every pregnancy, okay? Because it all depends on the viral load. It all depends on how prevalent that bacteria is in the vaginal canal. If mom has group B strep, this is the mom that if her water breaks at home, we want her to come in immediately. We don't want her to labor at home because she needs to receive antibiotics. Moms receive antibiotics during labor for group B strep. The gold standard antibiotic for this is penicillin G, and it's given about every 4 hours to moms until they deliver. Okay. If a mom delivers who has a diagnosis of group B strep to a newborn and that has not received treatment, the baby is at an increased risk for developing sepsis, for going septic. The baby also can develop other types of infectious agents that they may need to get long-term antibiotic use and they may need to be in the NICU after delivery. Typically, if a mom delivers and we have not received at least 2 or 3 doses of penicillin, that baby is going to need to stay for 48 hours and be monitored every 4 hours, their vital signs, their temps, all of that, to ensure that they're not developing any type of infection. What happens if we have a patient that needs surgery during pregnancy? So, the most common are appendicitis, so having an appendix removed, cholelithiasis, and cholecystitis, which is just having your gallstones or gallbladder inflammation and having your gallbladder out. So, appendicitis is the most common non-obstetric surgical emergency during pregnancy. That is that right lower quadrant pain, regardless of gestation, fever, chills, signs of infection. An appendectomy is recommended even if it's not evident. So even if they slightly suspect that the appendix is inflamed, we need to do an appendectomy because if it ruptures, that puts the mom at a risk for bleeds, for hemorrhaging, for being septic, which are way bigger of a deal than having this surgery done. Like I mentioned, cholelithiasis and cholecystitis are the gallstones or gallbladder inflammation. That is characterized by an epigastric or right upper quadrant pain, which may radiate, and we can do surgery on this as well. Okay. Any surgeries that need to be done during pregnancy need to be approved by the OBGYN as well as the CRNA to determine risk versus reward. Okay. Evaluate whether or not it is actually necessary. Trauma during pregnancy is common, but often underreported, unfortunately. So the most common in pregnancy are motor vehicle accidents and falls. Um, Trauma during pregnancy can increase fetal morbidity and mortality as high as 65%. So we need to definitely tell patients that if they experience a motor vehicle accident or have a fall, they need to come in to be evaluated. Okay. Um, Trauma during pregnancy can lead to miscarriage, preterm birth, premature rupture of membranes, uterine rupture, cesarean section, placental abruption, or stillbirth. Okay, so these are a big deal. Mechanism of trauma, so blunt. That's typically from a motor vehicle accident, but can be from domestic partner violence or falls. Penetrating means like a bullet or a stab wound. Thoracic is a pulmonary contusions as a result of blunt trauma. So, um, penetrating wounds that can cause a pneumothorax, basically. What are the mom's adaptations related to trauma? So, page 315 has a really excellent table for you. So, the optimal care for the patients after the trauma depends on the understanding of the pathophys of pregnancy itself, right? So, increased cardiac output due to decreased arterial pressure and systemic vascular resistance. That's what we typically see in labor and delivery. Okay, so if we have an increased amount of cardiac output, um, what is that going to mean for our patient after a trauma? What can we see? Or is this harder to stop a bleed in a pregnant woman? Is it harder to remain hemodynamically stable? So, fetal physiological characteristics. So, electronic fetal monitor may reflect maternal compromise. So, if mom is in really bad condition, baby might also be in a really bad condition. So, we need to monitor these patients for at least 4 hours after the trauma. Okay. So, even if a mom falls, she needs to be monitored for 4 hours minimum. Because we want to monitor for placental abruption or any other type of abnormality. So, if a mom comes in and she needs resuscitation from a trauma, from whatever, domestic violence, motor vehicle accident, she fell really bad, we need to focus on maternal resuscitation first before the baby. We need to make sure that she's in a left lateral uterine displacement way because we don't want that supine hypotension that can contribute to both maternal and fetal poor outcome. So we're going to put a wedge or a pillow or a blanket under the mom. Some causes of maternal cardiac arrest could be a hemorrhage, heart failure, amniotic fluid embolism, sepsis, aspiration, pneumonia, all that kind of stuff, okay? If we have to defibrillate a mom, We need to place the paddles on one rib interspace higher than usual to account for uterine displacement. Okay. Um, and then the heart is displaced by the large uterus, right? We know that all the internal organs are going to be shifting a little bit, so we need to take that into an account when we're placing the pads. Unfortunately, these things can happen. I hope that none of you have to experience them. But whenever we talk about perimortem cesarean birth, so if a mom comes in and she has been declared dead by a physician, we have 5 minutes within the minute of arrest, whenever that mom's heart stops, to get that baby out. So the birth of the infant improves both fetal and maternal survival chances. So we need to deliver that baby immediately if mom flatlines or if mom has been declared dead. We need to have that bedside emergency C-section. Okay. And like I said, I hope none of you ever have to encounter that because that is very traumatic. All right. So that covers everything that we need to talk about in regard to high risk antepartum care. Okay. Like I said, this was a lot of content. There's even more content that you need to review to expand upon your knowledge in your textbook. Please don't hesitate to reach out with any questions that you may have. And I hope this was helpful. Thank you guys so much.